Hi, everybody, and welcome to this episode of May I Interrupt. We're here at the American Academy of Optometry, where we're getting the opportunity to interview some really very interesting and cool people in the area of eye care. Until today. So, if I could, this is my partner in crime here, Dr. Jason Jedlicka.
Crime is right after that comment.
I'm Craig Norman. I guess our guest didn't hear it, though. He's not staring at me.
No, he's busy fixing his mic over there.
So,
Craig, I got to tell you, for day 3 of doing this and being at this meeting, you're looking pretty good today.
Thank you.
You look sharp.
I feel
I'm
sharp.
surprised you're holding up so well under all this.
I feel sharp.
Yeah.
But you know, in the time of COVID, and maybe it's because I'm taking a shower every day now.
Yeah, that would something new to start. Yeah, I like
exactly.
that, right? Yeah.
Exactly. Anyway, so today we have Dr. Clark Chang. Clark is a really valued expert in a number of areas within eye care, and we're going to explore some of that today. Clark, come on over.
Sure.
How are you doing? Welcome.
Good. Thank you. Thank you for having me.
Good to have you, Clark.
Thank you, Jason. Thank you, Craig.
Thank you.
I love how you guys it was so difficult to find words to describe me. You really dig deep.
No, I had plenty to say, but Craig always steals my thunder. So I was going to make some comment on how you must have the coolest case of eyeglass frames of anybody I've ever met. So
Take note.
Yeah.
I know, and this is like the third day in a row I've seen Clark with different, and I know Craig I was just saying on our last episode, this is the third day and different frames every day.
Yeah.
And your frames are very cool, Craig, and they look great on you. But they can't match Clark's
Well,
style.
Clark,
I mean, come on, guys.
Right.
The viewers out there, please vote.
Yeah.
1 for Clark,
Right.
2 for Craig.
Hey, so do you carry a case with like 6 slots or something with your eyeglasses for travel?
I have a case for each glasses, and they're in the little compartments when I travel. Yes.
Nice.
Right.
Nice.
Yes.
Like I have one of those as well, and it's very cool, right?
Yeah.
You don't have to worry about where they are. You just throw the box in.
I have a
and you're ready
case
to
for my one pair of glasses I own.
go. Yeah, one you own.
And then I have a large bag of all the contact lenses I like to wear. So
I
I'm
see.
just different. I do mine on eye instead of in front.
I see. So Clark, tell us what's going on today in your life.
Well,
Wait. Can I interrupt, please?
May you?
You're
Name of
doing
the
this.
show.
May you
You're doing
interrupt.
this again, Craig. Clark, tell us a little bit about you, how you got where you are, and what you do with your life every day.
Well, I couldn't do what I do without Jason and Craig. Of course, that's a given.
Okay.
Right?
All right.
Because they saw me when I was, without revealing their age, they saw me when I was up and coming. And
Yeah.
I'm still up and coming.
Yeah.
So,
You're getting toward the top of the hill here, I think.
no, but seriously, obviously, this is such a great time for, as you know, I was involved in a lot of, patient care and patient care related research in keratoconus and cross-linking. And so I just think that this is a very exciting time, especially with a lot of the options that we have available now, such as the specialty lenses that Jason designed. I mean, there's so many tools that we can now use to make our patients' life better. And I just really feel like there's no time like today.
Right.
Yeah, I can remember, again, dating myself 25-ish years ago when I started fitting specialty lenses. And you had a keratoconus patient come in, and it was basically corneal GPs or surgery.
Yeah.
And now we have so many things with the different types of lenses, the different types of treatments, putting aberration control on lenses. It's like, I feel like I don't ever want to get to the point where any of my patients ever need a graft, because we've managed them through all their treatment things properly before we get to that stage. So it's definitely the paradigm for managing keratoconus is completely different than it was even just 25 years ago.
So building on that a little bit, so Clark, now that cross-linking is, very widely used, right?
Right.
What do you foresee that to do, or what would its impact be as far as keratoconic patients over the next 10 or 15 years?
Right. That's such a great question, because there's so many angles to go at that in terms of what what both of you had just said, and that is we now have more than one option, right? It used to be it's a dichotomy of management where we basically force patients to say, do you want door number 1, corneal GP?
Right.
Do you want what's behind door number 2, corneal transplant? Or you don't want either, you're out of luck, right?
Right.
And that creates at least from my perspective, that creates a psychological barrier for patients. Regardless of how good the outcomes are from our perspective, what their vision is, they become harder and harder to manage, which I think is the reason why there's some studies that have been talked about with regard to, is there really a keratoconus personality?
Right.
And sometimes
Right.
I wonder how much of that is induced and how much that is really inherent in keratoconus patients. And so the difference in the paradigm that both of you had alluded to earlier is that if we can stabilize patients at hopefully the earliest possible point when they are progressing or when progression is being detected, that then has synergistic value to the optical treatment that we can provide patients to make their quality of life, not just their visual performances, but their quality of life as pristine as possible from very early on. And I think that psychologically will make their satisfaction much higher, just simply because they know that they were taken care of from the very beginning, and that we now have the tools to extend the longevity of the fact that, for example, the challenge used to be that every few months, every 6 months, every year, if they progress, corneal GP has to be changed because they're no longer comfortable.
Sure.
Well, if you could stabilize that, and that means that the lens that you work so hard at fitting your patients with, now they can work for a long period of time, and you're doing minor changes at every single visit. That impact to the patient, it's sort of like you're myope, knowing that, this time my prescription doesn't need to be updated. That's such a relief from their shoulder.
Yeah. Well, and one thing you mentioned that, and quality of life, really at the end of the day, that is maybe the most important part of this, and yet it's something we often don't consider. We're so focused on, is the fit good? Is the vision good? And it's like, okay, well, maybe the fit doesn't have to be perfect. Maybe the vision doesn't have to be perfect. The patient has a quality of life. And one thing that historically was when you talk to someone about keratoconus, we talked to that patient first time. Well, you have this condition, and it's a progressive condition. It's going to get worse. Where am I going to be in a year or 2 or 5? And cross-linking can kind of say, well, we hopefully have taken that progression concern off the patient's mind. So they're not living every day like, when is this going to get worse, or how long till I need it? No, you don't. Maybe 98% or whatever, that you don't have to worry necessarily about when it's going to get worse. It hopefully won't get worse. So that's a huge relief to somebody too, to say, I've taken your progressive condition and I've taken out the progression aspect of it for the most part.
I was looking at some iBank information recently. They put out that annual report and of course it's hard to judge, but there was a 20% decrease in the
utilization of corneal
Exactly. And now we don't know if that's time of COVID directly related. It's probably at least indirectly related. But I think as we look forward, that there probably is going to be a lessening of that.
I would think
corneas that are
be.
needed, and probably significant decrease, right?
And not to divert too far off Clark here, but one of the things that I just recently, and we were talking about this yesterday with aberration control, is what was our criteria in the past for sending someone for a graft was, well, their vision's, even with their corneal lens or scleral, they're still only 20/50, 20/60. Well, guess what? If I could correct their aberrations and get them back to 20/25, 20/30, that's a whole nother aspect of avoiding. I see grafts continuing to go down over time. First, it was because people aren't getting that as bad as they were. And now it's going to be, well, even in those patients that have progressed and didn't get crossing, we can correct their vision better than we ever can. And I think it's really exciting just to be able to say, because grafts are great when they work out great, but when they don't work out great, it can be ugly. And
and not to mention their progressive changes that our patient takes on over the lifespan of a graft, right? Loretta Shawkat had actually, one of our foremost expert on corneal transplant in the United States, had done a lot of research and had presented some of her findings about late onset astigmatism changes and refractive changes as a transplant ages. So again, that's another reason why, despite, even if we have good outcome, as Jason alluded to with corneal transplantation, there's always that hindrance that they know things, they may be late onset changes that they don't want to hear about or they hope not to experience. And I'm also having a lot of fun with these aberration control lenses, I have to say, given a lot of patients who are still not performing up to the point that they need in their daily lives, or they self-classify, oh, I failed scleral lenses, I failed this lens. And what they really meant was they didn't see what they needed to see in order to function. Right. And they tell themselves that therefore they go and tell their surgeons that I failed contact lenses, what's next for me? And I agree with Jason. So these, although I foresee that we're still going to get better with these aberration control algorithms.
Oh yeah, for sure.
Yeah, but currently it's already helping a lot of patients in my mind who have previously failed lenses because they feel like they have poor visual performances. And then if I could very quickly, I don't want to divert away from that topic because I would love to talk about some of our contact lens advancements, but with regard to the iBank report, like you said, there have been studies in Europe looking at comparing the rate of corneal transplant utilization X number of years prior to cross-linking, and then X numbers of years after cross-linking, and compare the rates over two different intervals, and given some time in between for hopefully cross-linking to kind of take some sort of effect, or at least for the impact to surface. And they did actually conclude that, and I believe one was from Norway, and concluded that there's about 25 to 50% of reduction in the need for corneal transplant after cross-linking had been introduced, years after cross-linking.
Like how many years after? 10 years?
It's either 3 or 7, because there were two. I think one may be 3 years, one may be 7 years, or over 7 years. I couldn't remember the exact, but it was in 2015, 14-ish that the publications were published.
Right.
So
well, it makes perfect sense. I mean, we would expect that.
Sure.
We would hope that. And again, the longer time goes by, that should just continue to drop, because there's always going to be a number of patients kind of who are beyond where cross-linking is going to save them. They've scarred up badly and they've just kind of put it off. And as they get older, they're probably going to still elect for it. But those patients are going to disappear for the most part, hopefully, because they will never have got to that point. So I think over time, we're just going to see it dropping too, which is exciting.
That it would be exciting.
Yep. So you mentioned specialty lenses, of course. So what's going on with specialty lenses with you these days? Anything different, or other than, of course,
the aberration controls that we talked about, which again I think is really exciting. We shouldn't underestimate the amount of work, though. I think that it still takes very careful patient selection. It takes a lot more, alert in terms of when patients are complaining about their lenses, are they complaining about residual high order aberration symptoms? I feel like some of us think that contact lens should take care of everything, and we sometimes don't hear patients' complaints, or we're not correlating their complaints because we're thinking, well, you're sitting in the chair, you're reading 20/20, so what's the problem? So I feel like there needs to be a shift of mindset as well, that the quality of vision is not the same as the visual acuity, and we need to kind of train ourselves to be more in tune to patients' feedback. But I think the other excitements in my life, and it's sad that these are the excitements in my life. That's right, I have no life. Are like basically just, I think, again, going back to what Jason has said, it wasn't long ago that the only thing we offer our patients were corneal GPs.
Right.
You want contact lenses as corneal GPs? Oh, they dislodged during your sports activity? Too bad, you have to buy another pair, right? And so now we have all these understanding of scleral shape, which again, both of you contributed a lot to that field of knowledge in our area. We have so much knowledge about scleral shape and how to handle that. Freeform optics and manufacturing of the lenses, and that had largely made scleral lenses, again, that's not the only lens, but it made it such a successful platform that we can offer any type of our patients, whether it's ocular surface, whether it's keratoconus. And we have to remember, keratoconus patients and irregular cornea patients, they have ocular surface diseases too.
Of course.
And there's been some studies that, when I know one of our colleagues, Amy Now, had actually, and Donald Korb's associate, they have been working on looking at prevalence of NGD and dry eyes in keratoconus patients. And so some exciting work coming, confirming what we know, and that is keratoconus patients can have dry eyes too, can have other ocular surface disease that may be benefited by the correct lens selection. And we don't just have scleral lenses, we still have continual improvement in corneal GP and hybrid lenses and soft custom lenses. I remember Greg being one of the first that brought in soft keratoconus lenses from UK into US. So all those tools are all in play, and it just, with great tools and great power comes responsibility. So we need to know how to use them and when to use them. So that is what I'm really excited about every day, learning from these two experts.
So do you think that, and I don't know if anybody has an answer for this, but do you think that the scleral lens market, which is like this, right? Do you think it's reaching this plateau at this point, as so many of those previous wearers of corneal lenses that were unsuccessful, as we sift through all of those, right? So they're not there as much anymore. Do we think that we're reaching a plateau as far as the usage?
Of specifically scleral lenses or all specialty lenses?
No, sclerals in particular.
I personally don't think that we have reached plateau for a few reasons. Number one, and again, if we just stay in the space of keratoconus patients just a little bit more, because again, scleral lenses can be for a lot of patients, not just keratoconus patients. But even if I just cherry pick my keratoconus space, we're now learning through epidemiology studies that keratoconus prevalence is higher than we used to think. So we're now able to, and with advanced technology such as shine fluke imaging, tomographers, Pentacam, Galilei, have your pick. We have Pentacam at Will's Eye, but having advanced instrumentation have also helped us identify more patients and understanding why they're having subpar optical performances, where the anterior surface sometimes are still not showing you any problem, right? There's no defect for us to catch, and now we know, oh, it's coming from other parts of the eye, of the cornea. So I think there's still just that alone. The detection technology getting so much better at letting us know what stage the keratoconus patients are at, and will allow us to be able to facilitate transition into scleral lenses sooner, and not to, and that's not to forget that you also, you have CSP that can tell you scleral profile. So all of a sudden you can predict which patient needs more of a customized perimeter because of the scleral toricity. And so we could stop them before they reach a point of thinking, oh, I failed another lens, I'm never going to try contact lenses again. So just for those two reasons, and there are many more, I think we have yet to see where the peak is with scleral lenses.
So interestingly enough, in the US, still the contact lens, the GP manufacturers, right? Still about 60% of the lenses they're making are corneal lenses.
Well, Ortho-K is a big part of that. Multifocals are, there's still no better method that we have of managing presbyopia than a good corneal GP multifocal, because of the translating effect. So, but I think, maybe what you're going with and what I'm thinking is, when you talk about scleral growth, it grew as we moved our irregular cornea patients into them. It grew as we moved our OSD patients into them. Where will the next bump be? Will there be some great revolution in presbyopia management? Do we figure out a way to put, induce higher order aberrations on a lens purposefully for the correction of presbyopia, and that'll be another bump? I think sclerals have so much more potential. We just have to find innovative ways to use them that we're not doing yet.
And if I may, just one more thing, because it's such a great point. I think exploration a different segment of population and knowing how to select them, how to apply different tools onto them, is going to bring about another wave of growth in specialty contact lens market and scleral lens contact lens market. And I recently gave a lecture on presbyopia management just to kind of piggyback on what Jason just said. I brought up this notion that, we obviously know we could do a lot with contact lens optics. We can use extended depth of focus optics, very similar to some of the new technology in IOLs that they use in cataract
Right.
surgery. What if we're able to understand patients' visual demands and their lifestyle and fit them properly using, say, different type of multifocal optics for presbyopes? Maybe it's small pupil aperture, because you could create peripheral blur in the contact
Sure.
lens to create an optical pupil,
Yeah.
right? And that gives you extended depth of focus. What if we use that to drive our future recommendation of what type of IOL lens that these patients should go into?
Right.
We're grooming them with our contact lens selection. And we know that whether it be monovision, whether it be just the sphericity level, because you can match that with an IOL, or whether it's extended depth of focus, whether optical or small pupil, we could use that to drive the selection of what lens surgeons should use in the future when patients are ready for cataract surgery. And a lot of them may be coming back to contact lenses too. So there's a lot there that I think will affect the way that our optometric colleagues will be managing these presbyopia patients in the future that I think are very exciting.
You know, what you just said is fascinating, really. If that was
Me or Jason?
No.
it's
Yeah,
usually
yeah,
Jason.
no, it's you. That the,
I don't ever say anything fascinating to Craig.
yeah. But to be able to use it as a diagnostic tool prior to surgery and not make some more permanent.
Well, and I think
Decision
the one
without
issue
that.
you run into, and we, in theory, have the ability to do that now or have, but when we wait till patients already have a significant cataract,
Right.
it's hard.
Exactly.
Because now you're looking through the blur of the cataract. But again, for those patients who are looking more of a refractive lens technology procedure, clear lens extraction with a, so this is the patient who's pre-cataract,
Yep.
but wants a refractive, option with an IOL, spot on. I mean, I think those patients would be great to simulate that with sclerals or some other device
Yeah.
or some other lens, yeah. So one thing I wanted to talk to you about, and I know that, again, you see a lot of patients who have had cross-linking, and just the hats you wear, you get to see a lot of what's going on in the cross-linking world. And yet you also have this expertise around the diagnosis and management of keratoconus, and you work with Oculus on a lot of fronts, talking about Pentacam interpretation. One of the things that I've wanted to look at, I don't know if you've looked at this at all, and again, having the aberration control or ability to measure it, is there a way for someone who doesn't have, an aberrometer, for example,
Right.
to utilize back surface corneal shape to predict the need for aberration correction? Can we, for example, and I've seen this a little bit on a handful of cases that I've looked at it, can I correlate somebody's HOA scan through a scleral, what's residual now,
Right.
with their Pentacam posterior float? And I think you find that they actually correlate
They
really
should.
well, and that perhaps even the steeper the posterior float, the higher the coma that's seen through the scleral. I mean, I think this is kind of fascinating. I think the Pentacam is such a amazing tool. I mean, I really do, what it can do for us in the realm of keratoconus, but also just in, there's probably things we haven't even unlocked with it yet.
Right.
So again, anything about your utilization of Pentacam for keratoconus patients that we could learn about?
Yeah. No, so again, obviously, in complete agreement with what Jason said, no surprise, and that is, we used to think that using any specialty lenses to neutralize higher order aberration that an irregular cornea patient is experiencing, why is there still a small group of patients that we know for a fact that they still underperform? And obviously the answer is residual high order aberration. And therefore, and knowing that the contribution, although we never could quite localize what do we exactly mean by residual high order aberration? And just like all things optics in human eye, majority of the contribution should be coming from your cornea. And therefore, majority of the residual aberration should then be coming from or stemming from your posterior cornea.
Right.
And that's the reason why then the residual HOA map should really match very closely to the posterior flow if you have access to a Pentacam.
Sounds like a study
instrument.
we need to do together.
Right, but my utilization though, another way to utilize it will be looking at it from the other perspective, and that is, how can we predict somebody who may potentially need these aberration control? And that is, if you examine the difference between their anterior and posterior elevation map, if there's great amount of misalignment, you likely want to educate the patient to say, hey, by the way, before I put the lenses on, there is a chance that you're likely going to need these advanced optics because some of the noises, because that's what I tell my patient, I talk to them about the aberration control as noise canceling technology in my contact lenses.
I like that, yeah.
Because they understand what that means in a headphone. So you have a lot of noise that may be created by by the back part of your lens that may even be worse once I correct everything on the interior by putting a contact lens on. Because what patients are confused with at times is that I think my vision is worse with the lens you gave me, and I thought it was supposed to help. And what it is they have neuroadapted to a lot of these aberration profiles. So even though it looks bad to you and I because we're normal cornea, their brain had tuned it down already like an auto tune. So they don't experience the amount of HOA that we think we are seeing in the instrument. So after we reduce that from the anterior side, all of a sudden the brain is saying, oh my God, this is so bad. The posterior residual is not great. So that's a different way of utilizing your looking at anterior and posterior and telling the patient ahead of time. They'll think that, oh my God, you're a magician. You actually predicted what exactly is going to happen.
Yeah, I think there's no question that everybody who works with keratoconus has those patients where you look and you look at their topographical map, you think, oh, this isn't that bad.
Right.
Mild, moderate case, perfect for a GP. I'm going to be a hero. Cornea's clear, you slap the lens on, 20/30 -2, best corrected.
Yeah.
What's going on here, you know? And those
sometimes
are the patients.
they think worse than how they started.
And maybe they are. Maybe because through their glasses, they're also 20/30 -2, but they're used to that optic and that visual presentation. They're not used to what you're showing them. So you might say, even though it's a little clearer, you mean this doesn't clear up all your doubles? And no, this is just as bad.
It's a different level of double, or my ghosting now moved from peripheral to central now. Now you've made it worse.
To an extent,
Right, and that's because we're not used to looking at where the source of the residual is coming from, and that's why something like Pentacam can be extremely helpful.
Yeah, well, again, Placido disc, wonderful tool. It was the standard again for corneal imaging forever. But when we do a Placido disc where you're only getting anterior information, then you go put a GP on, you think, well, I don't understand why this isn't making everything better. I'm masking all of it.
Right.
You haven't measured all of it, or you haven't seen all of it.
Correct.
That's why you. So that's where Pentacam really, it opens up a whole different perspective, not just again for managing keratoconus patients and looking for progression, but understanding their visual complications of the disease too.
This is one of the few times that I've seen Craig is lost for words because he's shocked by our brilliance.
Especially yours.
Is that fair to say?
See,
is that fair to say?
So. I think he was more shocked with how well you matched the neon of the light behind you. So.
That's great. So we just have a couple minutes left.
Okay.
And Jason, do you have any last questions
Well,
you'd like to ask Clark?
I know that Clark sees things that we don't get to see because of just what he gets to do, but is there anything that I should know as someone who co-manages cross-linking patients? Is there anything I should be looking for long-term with their corneal shape? Again, we're doing Pentacams before, we're doing Pentacams annually afterwards.
Right.
Is there anything that I should expect to see over time with these patients as I see more of them? Sure.
That's a really great question because it took us a long time to adapt because FDA just, in 2016, it was only 4 or 5 years ago when cross-linking was approved in US. And therefore, I feel like a lot of our colleagues are just adapting to this new paradigm that you had mentioned, stabilizing, extending the longevity of the contact lenses, having synergy between these two different treatment modality so that we can reduce the utilization of corneal transplant. But remember, collagen tissue turns over, right? Very slowly, but it turns over. It used to be at the beginning when I was doing, prior to FDA approval, when I was doing a lot of research work, collecting data on cross-linking, we used to think that that collagen may turn over in your cornea in 3 years. So we thought maybe the effect of cross-linking
Temporary.
would only be 3.
Okay.
Right.
However, now there are papers saying, publications saying it's probably 7 or longer. So you're seeing more long-term data from outside the US. And I know there's a 10-year outcome paper that's going to come out soon within US, that some of these papers have shown that despite supposed turnover rate of collagen tissue in your cornea, that patients, still 80-somewhat% of patients remain stable after 10 years, and the longest follow-up that I've read outside the US is up to 13. Okay, so there's no doubt that majority of our keratoconus patients are still going to, as long as they avoid eye rubbing. So that's one thing that we should continue to talk to them about, making sure that we're controlling their ocular surface disease, allergy, condition, that anything that provides stimulus for eye rubbing. But also not to forget that there's a small amount of patients that possibly could need a second treatment pending when they were treated. If they were treated very young, similar to how we tell patients about corneal transplant. If I'm going to do a transplant when you're 20, the likelihood of you needing, even if without rejection, the likelihood of you needing a second and a third is pretty good.
Right.
So therefore, if you're treating really early, and those are the more aggressive keratoconus patients, even with cross-linking, there is a need to use instruments like, topographer or tomographer like Pentacam to monitor whether or not their keratometry, their Kmax, or their elevation profile is actually changing. And there's a ARVO poster from 2020 that actually suggested, looking at over 7 years of follow-up, 7 or 10, that they recommend that we start watching patients very carefully with more regular examination starting at year 5 after cross-linking.
Okay.
So that's something that I would recommend that, I think we should be following these patients annually at least, but we should educate our patient as such so they're not surprised if they're the very small group of patients, 5-10%, that actually needs a second treatment. Because that is ultimately, again, talking about the psychological impact to patients. That is what's going to preserve not just their visual performance, but their quality of life in the long run.
Right.
Yeah, no, I agree. And I know that some of the early data showed a very low percent, 2% retreatment, but that was limited time frame.
1 year,
and the
2
longer
year.
we go out, we're seeing it'll probably grow. And I have my first retreatment in my own office recently with a college age keratoconic patient who had a repeat treatment about 4 years after his initials. So I agree, and I think that we can't forget that even though cross-linking does stabilize and is a benefit and can be a permanent, it's not necessarily always going to be. So don't forget about that. Yeah.
Excellent.
Yeah.
What a great discussion. Clark, thank you so much for coming by today.
Thank you for having me.
We got a couple of housekeeping items to take care of here before we let Clark go.
Okay.
First of all,
Let's do that.
don't forget about the merchandise. So golf balls. I lost my water bottle. There we go. Water bottles with May I Interrupt, Clark? There you go. Thank you for being on the show. And I'll do Craig's job here. I'll do Craig's job. If you scan our QR code here, this will take you to the May I Interrupt YouTube site where you can subscribe so you don't miss an episode ever. And you can go back and see our episodes from season 1 when I routinely showed up Craig on the set. So
Jason, you're pushing me out of this thing.
I am pushing
taking
you out
over
a
my
little bit,
responsibilities.
So I
You're
know.
talking about what I'm supposed to talk about. What's the deal?
Craig, I've been lobbying for a new partner for a while. So
Vote one. Number one
but
for Clark.
Clark would be Clark.
but trust me, Craig, if we ever did bump you off the show, I'd still have you back as a guest once in a while.
Wow, that is so great. Thank you, everybody, to this episode of May I Interrupt. Thank you for Oculus for sponsoring this. And really, it's a wonderful thing that we're doing here at the American Academy of Optometry meeting. Please stay tuned for future episodes. Thank you.